Good morning, everyone. It's 8 o'clock. This is Shannon Switkowski from the Cardio-ECHO Hub. Good morning. This morning, I'll remind you to enter your name, your practice location, and your role into the chat box so that we can record your attendance. If you do have questions today, you could just go ahead and enter it into the chat, or you could wait until we ask for questions and answers. Also, if you are not speaking, please remember to mute your microphone. We do have a couple of folks who are on a telephone call, so I'm going to go ahead and call your number out, and if you just go ahead and say your name so we can record who you are. 216-952-1354.
Michael Constant.
Oh, hi, Mike. Good morning.
Good morning.
And we have 937-836-2332.
Mary Jo Trout with Wright State Geriatrics.
Thank you, Mary Jo.
You're welcome.
Nope. Okay. We will go around the room here and introduce ourselves. I will note that Dr. Rao has a conflict today, so Dr. Bolen is going to be the presenter and the facilitator. So I'm Shannon Switkowski. I'm the clinic coordinator.
Jackson Wright, work with cardio.
I'm Shari Bolen, PI for cardio.
Hi there, Jessie Lewis, project manager here at CASE. I'm Ann Nevar, program director for cardio.
And I'm Rick Carnacci. I'm the web content producer for cardio.
Great. So good morning. I know I'll talk in a little bit higher voice than Gotham probably, but we'll do our best this morning. Our structure will be the same, a didactic presentation with the 2 case studies and then a wrap up and a post-clinic survey. Next slide. And go to the next slide. And these are just our I'm going to talk about team-based care approaches to hypertension management today. Next slide. And these are our disclosure statements. They're the same as they have been each week. You can take a look at those. There's nothing new there. Next slide. So today I'm going to go through describing the rationale for team-based care. I'll identify some team-based care approaches shown to improve blood pressure control across diverse populations. And we'll talk a little bit about resources available to implement these approaches. Next slide. So I like why team-based care. So I like this picture because I think it really demonstrates the trust involved when we're working as a team together to really have great patient outcomes. And of course, I'm especially fearful for this boy at the top since I have a terrible fear of heights. But you know, just really thinking about how we really in patient care need to do these same kinds of trusting relationships to really build the patient's outcomes at the top of the pyramid. Next slide. And I wanted to briefly bring up these 2 studies because I think it just highlights the sort of time it takes us to care for our patients in primary care. So for an average patient panel size of 2,500 patients, it's been estimated that we would need 11 to 18 hours a day to take care of all of their needs. And so just another reason why we really need a team to help us so we're not spending as much time solo doing these tasks. Next slide. So besides time, I think most of us recognize that we combine skills from across team members so we can have a greater impact, and that's really the value of team changes and team-based care. And this was a systematic review where they really looked at quality improvement strategies for hypertension management and found that, and I know it's really hard to read all the little details there, but all the way on the end, there's team changes, and there were 20 studies that evaluated a team change as a way to improve blood pressure control and showed significant improvements in control using those approaches. And it didn't necessarily mean adding a team member. It could have been just changing the function of that team member. Next slide. So these are some of the elements that were used in those studies on team changes. There were sort of two categories. One was transferring all responsibility around blood pressure to a team member. And we've seen this ourselves with pharmacist-led interventions, or if a nurse practitioner takes care of a panel of patients, maybe setting up a special blood pressure visit session. So those are the kinds of things that they described. And then also work site was part of those studies, where if you were the primary care provider, you might defer to a work site around blood pressure management and protocols, so that patient could be taken care of more seamlessly without having to take off from work. There was shared responsibility was another element for those team changes. So there were studies where they looked at things like a pharmacist would review a case and give provider the recommendations around medication management, and also shared responsibilities such as a nurse-led visit, where the provider may still be making treatment intensifications, but the nurse may be focused more on medication adherence and lifestyle management. And some of the interventions that were used repeatedly in those team-based care approaches were home blood pressure monitoring and use of a treatment protocol. Next slide. So I wanted to talk a little bit about team-based interventions within safety net populations, because some of those studies have been a little more recent. Next slide. And I know Kaiser is not a safety net health system, so that you may find that surprising that that's on the next slide, but it has been translated into the safety net. So I wanted to just show briefly the Kaiser hypertension program improvements, which really are those black circles, and showed that from 2001 to 2009, they went from 42% of their patients under good control to 80%, and that was in their California system. And then the regular HEDIS measure for blood pressure control are sort of the white squares and the black triangles, or the national HEDIS measures. And you can see there were some improvements in other areas, but that didn't mirror the amount of improvement that was seen in the Kaiser system during this period of time. Next slide. And this just really looks at disparities. So the top line is the white population, and the bottom line in the black circles are the Black or African-American population within Kaiser. And this just shows that from 2008 to 2014, they were able to reduce the gap in blood pressure control between groups, although they did not eliminate that disparity. Next slide. So many of you on this call actually know what Kaiser did, because we've talked about this in some of our regional work and also across the state. But just to go over that so everybody has heard it, it's really accurate blood pressure measurement by the staff, including repeating the blood pressure if the first blood pressure was elevated. They did monthly staff-led hypertension visits until the blood pressure was controlled. They had a treatment algorithm that prioritized once daily low-cost medications. And then they had coordinated outreach to patients with elevated blood pressure using an electronic health record-based registry. So if the patient's last blood pressure was high, but they didn't have an appointment coming up, they would do outreach to get those patients in. And then they had a communication curriculum that was focused on building trusting relationships with patients. Next slide. And these are data from Better Health Partnership, which is a regional health improvement collaborative in Northeast Ohio. And we translated this best practice within many of our lower performing safety net clinics across the region. And what you can see here in about our 200,000 patients in our region, that we really reduced the gap in blood pressure control for our Medicaid and uninsured patients, our African American and Hispanic patients, and low income and low education. And although we didn't eliminate the disparity for African Americans versus whites, we did reduce that. So that just demonstrates the ability to translate these kinds of interventions into safety net populations. Next slide. So this is a story, an email I got from a colleague of mine when we did this at Metro Health, where I work, and there's 17 primary care clinics there. And in addition to doing these 5 elements within primary care, we also had our specialty clinics doing repeat blood pressures and automatically scheduling them into our nurse visits in primary care, so that there wasn't a challenge in getting them scheduled. So they really saw, what he emailed to me was, I saw a patient this week who has not followed up with me in over 2 years. He recently came in to see an eye doctor who found his blood pressure was high. He got scheduled in a nurse visit in primary care a few weeks later where his blood pressure was still high. And then he got scheduled to see me where his blood pressure was high and I tested his A1C, which was 11.1. And he wrote to me, population health, here we come. So I think this is a nice story of how the system can work well if you get these systems set up in place to get them back to see the provider. And then obviously he worked with the patient to try and get those under control. Next slide. Beyond some of these health system approaches, a lot of people are investigating ways to use community health workers or health coaches or patient navigators. So I think this is just a study demonstrating that the effectiveness of those approaches, and this was done in San Francisco. They randomized patients to health coaches plus or minus home titration of medications. And they received an average of 10 health coach visits in 6 months. The range of visits was 0 to 27. And the blood pressure decreased on average 22 millimeters of mercury pre and post for both groups, whether they did home titration or not. So that, I think that was really interesting. And also they have some modules around the training they gave to their health coaches so we can help hook people up with some of those resources if they have interest. Next slide. So I put this here just to remind us that our patients are also part of our team-based care. And this was, I think, a really neat intervention, even though I know DVDs are a bit obsolete right now, but you can envision other ways of doing this, such as YouTube or other technologies. But, you know, sort of a really low cost intervention where they really randomize patients to get these 3 DVDs of patient stories from their clinic or from their region. And really, they were talking about things like how they address their lifestyle management, how they address their medications. And then there were some learn more sections about those pieces versus sort of an attention DVD, which just shared information about, I think it was colorectal cancer, it might've been blood pressure, but it wasn't based on stories. And of those with uncontrolled blood pressure, there was an 11 millimeter mercury greater reduction in the patient stories DVD group. So this is just an example of how we can engage with patients and really rely on the resilience that they have and the stories they have of how they've been able to improve outcomes. And so we can use that in our work. Next slide. I put this here because we're really, I think a lot of our systems are exploring how we use community organizations or partner with communities as part of our team-based approaches. I don't think we have a lot of outcome data yet on this in terms of blood pressure control, but I think it'll be interesting to see how that plays out in the next few years as we get more people doing these kinds of interventions. At one of our clinics at Metro Health, we are having medical assistants refer patients with elevated blood pressure to 211. And 211 is, for those of you who are not familiar with it, has an extensive database of community resources for social determinants of health and healthcare education needs. And so we referred about 50, in 1 month, we referred 50% of our patients were interested in the referral. And our navigation, the 211 navigation specialist reached out to them and contacted the majority. And then their median number of needs were about 4 per patient. And you can see in the graph some of the needs that arose. As you might expect, food insecurity, utility assistance, housing were issues. We also provided low cost or free recreational opportunities, and that was something of interest to the patients that were referred. And healthcare needs were actually things like the Chronic Disease Self-Management Program. The American Heart Association has an educational program. So there was some educational interest by our patients as well. And I put down here a reference to the Annals of Family Medicine at the bottom of the slide, because that article just came out in 2018 where they talked about screening for social determinants of health at 3 clinics. I think that's one of the first studies that's looked at that. And I thought slightly different results than we found and really interesting information. So again, I think this is sort of novel. It's in an exploration phase, and it'll be interesting to see how that impacts our patients over time. Next slide. So I added this slide about motivating teams, and actually while I'm talking about it, I'd love for folks to chat in what they do, because I think this group has a lot of experience in motivating teams and quality improvement within your clinic. So I'd love for you to just share what's worked well for you by chat, so that everybody could see some of the things that have worked for you all. But I put the Olympic team up here because, that would be sort of the gold standard. It'd be great if we could get sort of these Olympic teams in our offices that just move so efficiently and work well together. And I know that can often be a challenge. I'm sharing some things here that's worked well, I think, for us in the region. And this is sort of, and I bolded some things that I think we don't do as often as we do some of the others. So for instance, I think we underestimate the need to communicate regularly with staff and providers around the rationale and also the impact of the things that we're doing, and sharing sort of the data on how we're improving. So that's something I highlighted here. Piloting change with motivated staff, I think, works really well. If you're trying to get started and you have, some people that are less enthusiastic. I put in bold here, don't let small barriers stop or change the process. Sometimes people have, something that occurs maybe with 5 or 10% of your patients, and it's a real issue, but it doesn't mean that the whole process needs to stop. It just means you need to address that issue or deal with that segment in a different way as well. Baking quality improvement into annual reviews for staff. We've tried to align ours with performance improvement projects as well for our nurses, so that things are more aligned with the quality improvement work we're doing. We often reward our sites for participating at sort of the end of a project. And we'll also sometimes do competitions over a couple months, where if we're doing it among all the clinics, and then we'll reward the highest performers or highest improvers. So that's another strategy we've used. And then showing your team you value them. I think, in our heads, I think how appreciative I am of a certain staff member, but I don't express it necessarily. So I think that verbal expression is really important in how we value our team members. So I'd love it if you guys share things that have worked for you by chat, but we're gonna, I think there was some, right. So somebody mentioned monthly staff meetings, recognizing others' contributions, team walks. I love that. Participation in community screenings and events. Great. That's wonderful. And so feel free to share others as they come up in the chat. And I know we're a little bit tight on time, and I want to make sure I get to the case studies. So we'll move on to the next slide, which this is just some resources available to assist with implementation. I do want to make a point that for those, we have a Medicaid-funded hypertension quality improvement project across the state, and that wave 2 is beginning April 15th. So I know some people are part of our wave 1, but if you wanted to hear more about that, just contact me by email. My email's there. Or if you have Shannon's email, she can always hook you up with me as well. And then there's some other programs, and I'm happy to talk about those with folks if there's interest. Next slide. So in summary, I think team-based care models work to improve blood pressure control and reduce clinician burden. Implementation of models does require time and effort, but it can be done successfully within safety net practices. Resources do exist to assist with implementation, and I'm happy to talk to folks about that. And I really didn't get into this due to time, but our payment models need to better support team-based approaches. I think there's an evolution toward that with the total cost of care and accountable care organizations. But I think we'll need to do more work with that. And I know Dr. Wright's team and Dr. Przinsky's team, Best Practices with Cardio, is looking into additional information on that we'll hopefully share in the future as well. Next slide. I think so hopefully I've left you with lots of interesting questions, and I like this picture on the left as opposed to this boy on the right, but I think we have 1 minute or so for questions, and then we'll move into the cases. I saw in the chat there was a question about what's meant by staff-led visits, and I think what was done by Kaiser was nurse or medical assistant led visits, but I think that could be what we've seen in our region when we rolled that out is a variety of options for that. And so that can be done in a variety of ways. Cardio Collaborative is doing a statewide conference on May 17th. Dr. La Princess Brewer, who's a cardiologist, has done a lot of work working with communities to improve cardiovascular health. That's going to be in Columbus. So would love to have you guys come to that if you're able to. We're accepting workshop or poster and oral submissions via abstract, and those need to be submitted by March 8th. So if you guys have great work you're doing around quality improvement in your clinics, I know some of you are doing a lot of those things around cardiovascular conditions. We'd love to have you submit those by March 8th, and then potentially presenting those for our conference. And you can register now if you want as well. So next slide, I think, is just the wrap up by Shannon.
Thanks everyone for joining today. I'll just remind you that you should have received your post-clinic survey. It's open until 5 o'clock tomorrow. And next week, please join us on March 7th with Dr. Michael Holliday from University of Cincinnati Medical Center for what's new in recommendations for pharmacotherapy. Thanks everyone. Have a great day.
Thank you guys. See you.